Welcome to the explainer. We've all been there, right? That moment a patient comes in with chest pain and your mind just starts racing. Well, today we're going to turn that anxiety into a clear, confident clinical framework. We're going to break down how to diagnose an acute MI step by step.
Okay, let's just dive right into it. A patient is in front of you, they're clutching their chest. The clock is officially ticking. This is one of the highest stakes scenarios you're going to face, but with the right approach, you can move from feeling overwhelmed to being decisive. So what's your next move?
Here's how we're going to tackle this. First, we'll get the definition straight. Then, we'll talk about that first encounter with the patient. After that, we'll cover the essential diagnostic tools you'll need. We'll pull it all together to make the diagnosis, and finally, we'll get into the really interesting part, classifying the different types of MI.
All right, first things first. Before we can diagnose anything, we need to be speaking the same language. Getting this definition right is absolutely crucial because honestly, everything else we do flows from it. So here's the key distinction you have to burn into your brain. Myocardial injury is not the same thing as a myocardial infarction. Injury just means there's some damage, which we see with a positive troponin. But an infarction, that's injury happening in the specific context of ischemia, a lack of blood flow. You absolutely need both.
And this leads us to the big three players in acute coronary syndrome, or ACS. Think of it this way. A STEMI is the obvious, raging fire that you can see immediately on the ECG with ST elevation. An NSTEMI is more like a smoldering fire. You don't see those big changes on the ECG, but the troponin is elevated, telling you there's definitely damage. An unstable angina? That's the smell of smoke. It's a warning sign of ischemia, but there's no actual fire yet, no elevated troponin.
Okay, let's get out of the textbook and into the room with the patient. This is where your clinical skills, your ability to really listen and observe, make all the difference.
You have to cast a really wide net here. Your suspicion for MI should be triggered by more than just chest pain. I'm talking shortness of breath, a patient who suddenly develops heart failure. Even someone who comes in after a cardiac arrest. Your initial suspicion is what gets the ball rolling. And with MI, time is muscle.
Now, we all know the textbook description, right? The crushing substernal chest pain radiating to the left arm. And sure, you'll see that. But you have to remember that atypical symptoms are incredibly common, especially in women, older patients, and people with diabetes. They might just feel weak or nauseous or just off.
And get this, a full 1/3 of patients who are confirmed to be having an MI have no chest pain whatsoever when they present. Let that sink in for a second. 1 out of every 3 patients won't have the single symptom we're all taught to look for. That's why your index of suspicion has to be so high.
Okay, so your clinical suspicion is up. Now it's time to get some objective data. Let's break out your 2 most powerful, most essential tools in the workup. Tool number 1 is the ECG. Think of it as an electrical snapshot of the heart at this very moment. It is your first, most critical piece of the puzzle, and the national goal is to get it done and read within 10 minutes of the patient walking in the door. It's what lets you immediately triage them into one of a few critical pathways.
Now, don't worry about memorizing every single number on this slide right now. The point is this: calling a STEMI isn't a gut feeling. It is a diagnosis based on very specific objective criteria. You can't just eyeball it and say, looks high. You have to know the rules and apply them.
And our second huge tool is cardiac troponin. If the ECG is like a smoke detector looking for electrical trouble, the troponin is the fire alarm. It only goes off when there's been actual cell death, real injury to the heart muscle.
And here is one of the most important lessons you will learn on the wards. A single troponin is almost useless. I can't tell you how many times I've seen a patient with a perfect story for an MI whose first troponin is stone cold normal. You have to do serial testing. A negative test on arrival does not rule out an MI. You've got to check it again in a few hours.
This concept right here is what separates the novices from the experts. See, lots of things can cause a chronically elevated troponin, like kidney disease. But in those cases, the level is just high. It's a flat line. What we're looking for in an acute MI is a dynamic change. We want to see a clear rise and then a fall. That pattern, that trend, is the real story.
All right, here we go. This is the moment we put it all together. We've got the patient's story, the ECG findings, and our troponin data. Let's synthesize this into an official diagnosis.
So think of this as your official checklist.
To diagnose an acute MI, you need that dynamic rise and fall of troponin. That's non-negotiable. But that's not enough. You also need at least one other piece of supporting evidence. Things like classic ischemic symptoms, or new changes on the ECG, or even seeing a new problem on an imaging study. It's the troponin plus something else that makes the diagnosis.
Okay, you did it. You made the diagnosis. That's a huge step. But to be a really sharp clinician, you need to go one step further and ask, what type of MI is this? This is where the real nuance comes in.
The simplest way to think about this is type 1 versus type 2. A type 1 MI is a plumbing problem. A plaque in a coronary artery ruptures, a clot forms, and it blocks the pipe. Simple as that. A type 2 MI, on the other hand, is a supply and demand problem. The pipes might be totally fine, but the heart is working so hard, maybe from severe sepsis or profound anemia, that there just isn't enough oxygen to go around.
And as you can see, the kind of patient who gets a type 2 MI often looks a little different. They tend to be a bit older, and they're way more likely to have other serious medical problems going on, like heart failure or kidney disease. So when you see a troponin bump in a really sick patient, you have to ask yourself, is this a new clot, or is their heart just struggling under the strain of everything else?
And this is why it matters so much. Look at the difference in who goes to the cath lab. For a type 1 MI, the plumbing problem, a lot of them get an angiogram because you need to go in and fix that blocked pipe. But for a type 2, the supply/demand problem, you don't fix it by stenting a clean artery. You fix it by treating the underlying issue, like giving blood for anemia or treating the sepsis.
So at the end of the day, remember this. Making this diagnosis is an integrative process. You have to be a detective. You combine the patient's story, the ECG, and that dynamic pattern of troponins. You never, ever rely on just one piece of information alone.
Because making the diagnosis, that isn't the finish line. It's actually the starting gun. It kicks off a whole cascade of critical decisions about treatment, risk stratification, and long-term care. So you've made the diagnosis. The real question is, what are you going to do about it?